Hyperplastic polyps and cessile-serrated lesions, this can be a challenge because the endoscopic appearance is similar, but typically true hyperplastic polyps will be smaller than SSLs. You may be able to see lacy blood vessels kind of overlying the lesion. They're pale in appearance, and certainly if they're in the distal colon or rectosigmoid area, they're fairly easy to distinguish compared to sessile-serrated lesions, which are more likely to be located in the proximal colon and typically will have a mucus cap on the lesion, so a yellowish appearance, are larger than hyperplastic polyps on average. They may have a rim of debris around the lesion and what we call a cloud-like surface where looks like sort of a transparent cloud-like appearance on the mucosa. And if you look at blood vessels around sessile-serrated lesions, sometimes you'll see that the mucosal blood vessels sort of stop at the margin of the polyp, and that can be a sign of a sessile-serrated lesion. So it's not only the characteristics of the lesion itself, but sometimes it helps to look at the surrounding mucosa. And certainly computer-aided detection and as we develop more systems for computer-aided diagnosis, that will also help us identify and distinguish these lesions. So the best strategies for resection of large serrated lesions, I personally favor cold techniques, meaning using cold snares to remove serrated lesions. This has to do with improved safety profile of cold resection compared to electrosurgery or hot snare techniques or traditional hot snare EMR. And so I use cold snares on nearly all the serrated polyps that I encounter in my practice, and that includes larger serrated polyps greater than 1 centimeter in size or greater than 2 centimeters in size even. And that can be done with submucosal injection or without, depending on the shape and position of the lesion. Sometimes submucosal injectate does help define the borders of the lesion, particularly if you include some methylene blue dye. But sometimes that's not needed if you can clearly define the lesion. So strategies for piecemeal cold snare resection. It's important to, prior to your resection, really understanding where those borders are, making sure that you capture a rim of normal tissue around the lesion to ensure that it's completely resected. And marching sort of from one side of the lesion towards the other so that you can anchor your snare in that polypectomy defect as you move across the lesion to ensure that it's completely resected. We have found that in contrast to adenomatous polyps, clipping the polypectomy bed is not necessary to reduce the risk of post-polypectomy bleeding after cold resection, but paying careful attention to ensure that you've done a complete resection and capturing all those tissue pieces. The downside, I think, of piecemeal cold resection is a higher rate of residual neoplasia on follow-up, and there is some risk of hindering your pathology interpretation with piecemeal versus en-bloc resection. But for most low-risk sessile serrated lesions, that don't have different morphology within the same lesion, the risk of dysplasia or cancer is quite low, and thus piecemeal resection is acceptable. I'll also say that cold snares, because of the architecture of the serrated lesions, tend to cut through the serrated lesions quite easily, in contrast to bulkier adenomatous lesions where a cold snare may have a difficult time cutting through the tissue. So certainly when I diagnose someone with serrated polyposis, criteria 1 or 2, that subsequent colonoscopy I am recommending at 1 year. And that's because for the individual patient it's hard to predict their risk of metachronous neoplasia. But at that second exam, if the polyp burden is lower, I'm only encountering smaller polyps, I think for some patients it is appropriate to space out that surveillance interval to 2 years from 1 year. And that approach has been validated in a group of serrated polyposis patients from the Netherlands. And I think some guidelines allow for 1 to 2 year surveillance in patients with serrated polyposis. It does appear that the patients who meet criterion 2 of the WHO definition for serrated polyposis are at a lower risk of colon cancer overall. And so for those patients in particular, I think it's reasonable to think about spacing out their surveillance interval to more than 1 year.